Anshuman Sinha, Gayatri Ravulpati. If anybody is present, please join. Sorry? You have a talk? Yeah. I'm talking of this.
Should I start?
Yes, I think it's time, so we have to start. And this session is on retina realities. I am Dr. R.B. Jain. I am chairing this session. So I invite Dr. Saurav Santra to give the first talk on Beyond the Surface, Approach to Internal Limiting Membrane Peeling Surgery.
Hello, good morning everyone. So today my topic is Beyond the Surface, Approach to ILM Peeling Surgery. So what are the indications of ILM peeling? Full thickness macular hole, VMT with or without ERM, optic disc maculopathy, myopic foveositis, sub-ILM hemorrhage, and non-resolving macular edema. This is the international classification of macular hole. So stage 2 and beyond we do pars plana vitrectomy. Stage 1 we observe. So what is macular hole? It's a full thickness defect in the foveal center. Prevalence is 4 out of 1,000, mostly above 63 years of age, more prevalent in females. Incidence in the fellow eye is 5 to 16%. On slit lamp, we see a round excavation with well-defined borders interrupting brim of slit lamp, and overlying semi-translucent tissue, which we call the pseudo-operculum, and associated with cuff of subretinal fluid. Clinical features: vision depends upon size, location, and stage of the macular hole. Patients generally complain of difficulty in near vision and metamorphopsia. In advanced stages, there is scotoma and micropsia. Management: stage 1 holes with good visual acuity are observed. Stage 2 and above macular holes, we do a pars plana vitrectomy with or without ILM peeling, depending on the size of the macular hole and the internal tamponade. So macular hole cover is done with, most commonly is done with inverted ILM peeling or multi-layered. Sometimes lens capsule, amniotic membrane, or retinal graft can also be used to cover the hole. Internal tamponade depends upon the size of the macular hole. Sometimes we can use silicone oil too. Prone position depends upon the tamponade. It may last for 3 days to 3 weeks. So this is a normal full thickness macular hole surgery. Next, I'll be sharing some of different case scenarios with full thickness macular hole. So this was a case of high myope patient with full thickness macular hole, but with ERM. So first we have to peel the ERM, otherwise we can't peel the ILM. So ERM was removed, and it was a large hole with, and the patient was high myopic. So next was a case of traumatic full thickness macular hole. In such patients, mostly the PVD induction is very important in this younger age group. Otherwise, ILM peeling is mostly easy to do, but the PVD induction is the difficult part in such young cases. Next is a RD with full thickness macular hole. In this case, some surgeons prefer doing a ILM peeling in such cases without PFCL, but I prefer doing ILM peeling under PFCL. It helps to, it gives us support. So this is the pre-op OCT image, and this is the post-op image. The retina is settled with closed macular hole. This was a case done elsewhere. Patient came to me with recurrent inferior RD with full thickness macular hole, and a subretinal band was traversing through the hole. So we have to remove all the tractions to secure to close the macular hole and to settle the retina. So at first I did a ILM peeling under the PFCL. It was a large macular hole, is mostly tractional. Then I removed the subretinal band, and you have to remove all the tractions in these cases. There was a ERM near the inferior arcade also, so you have to remove it also, otherwise the retina won't get settled. So this was the pre-op OCT image, and this is the post-op image. So basically my take-home points for better visibility of the ILM, there is no harm in staining multiple times. You have to remove all the membranes on traction that are associated with the macular hole. It's better to create the initial edge of ILM edge. It's better to do it inferiorly. An area of the ILM peeling depends on the size of the macular hole. In high myopes, to reach the ILM, posterior sclerotomy can also be done, and entering the eye without the cannula, you can do that also. In RD with full thickness macular hole, better to do ILM peeling under PFCL. Prone positioning is crucial post-surgery. You have to explain there is a prolonged recovery time, and patient needs to be counseled properly. Thank you.
Very nicely performed surgeries.
Thank you, ma'am.
Yeah. So thank you.
Thank you.
Any questions from the audience?
We can take questions.
Okay, sir. So let me invite the next speaker, Dr. Saurabh Luthra, for presenting his tips and tricks in macular hole surgery.
Good morning, everyone. Mike. Good morning, everyone.
Mike, please, Mike.
Yeah, good morning everyone, respected chairpersons. I thank AIOS for this opportunity. I'll be just going through tips and tricks in macular hole surgery. So the advent of small gauge instrumentation has revolutionized current vitreoretinal surgery. Smaller port size with port optimization and smaller sphere of influence makes these cutters more efficient. Multifunctionality rendered by smaller, more dexterous tips helps reduce need for additional instrumentation. This is my first case with a full thickness macular hole in the left eye, and you can see the vision was 3/60. And these were the macular hole parameters. I'll just quickly go to the surgery. So initiating PVD with triamcinolone acetonide. So this is a 27 gauge surgery. For some time I was using 27 gauge for macular hole surgery. But now I've gone back to 25 gauge because actually in India the reusability is also an important criteria. And there was a tool flex which I noticed, so the number of cases I could do with a single pack was not as many. And just taking it to the edge of the hole but not peeling across is what I do. This patient did well with a vision of 660 final, and another case with 5/60, and this is what is known as temporal flap. In this, you will see that a large temporal flap is just reflected over the hole and it covers it as a scaffold all across. So you don't really peel too much and leave that. And then of course to relieve the tangential traction, remove the rest of the ILM from elsewhere, so that there is a centripetal movement of the retina towards the hole. So anyway, so this patient also did well. Another case of macular hole 3/60, and this is the cabbage technique, also known as cabbage technique, where multiple flaps are reflected onto the hole, and they are left there. So you don't really have to stuff the hole, because there's an inadvertent chance of touching the RPE underlying the hole, and that can damage. You can also catch the edge of the hole, cause bleeding. So just with the closed tip of the 25 gauge, the blunt tip, I'm just apposing the flaps onto the hole, and then air fluid exchange. This patient did well with the improvement of vision with 6/60. So there is still little bit restoration of the kind of layers, but not that much. But on successive follow-up, it does realign the neurosensory retina layers. Another case. So this is an LHEP, lamellar hole with endothelial proliferation, and this is a hallmark where I'll just show you the video because of paucity of time. I'll just show you the videos. In this, you will notice that there is a yellowish reflex around the hole, and if you try to take the ILM towards the hole, there is a resistance, and I had to stain at least 3-4 times, 5-6 times in this case, and that tells that this is an LHEP. These are very tough cases to manage, because the ILM just doesn't budge towards the hole. It just stops short of the hole. There's this fibrous tissue just around the hole which doesn't allow you to take the ILM towards the hole. I had to stain multiple times to kind of get towards the hole with the ILM. And you can see some white fibrous tissue also coming along with the ILM. So LHEP is again a kind of a tough condition to manage, and this patient improved to 624. This is a failed macular hole surgery. So I'm removing the gas which was there previously, and on restaining I found that the flaps had just opened up. And so what I did is I use the finesse a lot now, the 25 gauge loop, and just reflect those. So they are not as densely attached as the native ILM would be, but they are still kind of semi-attached to the area around the hole. So just with the finesse loop, I just make them free and just push it towards the hole. So this patient did well too. Now I'll just show you a couple of two videos where I've used PFCL. I'll go to the video because there's paucity of time. So large macular hole, and I hope the video plays. This is a technique which I'm using for large macular holes. You can see it on the intra-op OCT, large macular hole. Peel the ILM, flaps. And then I'm noticing that the flaps again are not inside the hole, they are around the hole. So just put a PFCL bubble. And then again with the finesse loop, I find it is very atraumatic. I can just push the flaps back into the hole and then do an air fluid exchange, and the end you remove the PFCL bubble. So that if the PFCL bubble you remove initially, then the flaps will again come out. But somehow PFCL has this quality that the flaps, they adhere to the underlying RP. So this patient did well. And I won't show this. This is a similar case I managed. I'll just show you one last video. So this is a large macular hole. I think I'll show you, I'll just go to the last video because I'm seeing that the time is over. So this is a giant macular hole which I managed. So you can see it's 2.29 millimeters, and in another section 2.46 millimeters. That was the size of the hole. So this patient had already been operated for macular hole. There was an RD inferiorly and nasally in the periphery. So I'm trying to find some ILM, can't find the ILM. I put a chandelier, I put a PFCL bubble, try to stay in the nasal side looking for ILM, again no ILM. So the inferior RD, I've just made marks there and making a autologous retinal transplant, and with under the PFCL with 2 forceps and the chandelier illumination, I placed it on the hole. I'll just finish, sir. And then lasering off the retinotomy with after air fluid exchange, and there was a pocket of SRF which was still there nasally. I drained that and put oil in the end, and this is how the patient looks post-operatively, and it's kind of integrating, but the patient is still on follow-up. So I won't go into the discussion, I'll just end with my conclusions. So 27 gauge has its advantages, multifunctionality, and small dexterous tip. PFCL assisted inverted ILM flap technique can be used as primary approach for large and chronic macular holes, recurrent macular holes. PFCL acts as an efficient third hand, and intra-op OCT is a useful third guide adjunct in achieving successful outcome. Retinal autograft with silicon oil tamponade can be used to salvage giant macular holes. Thank you.
Just one question, sir. Can I ask? Yeah. So any improvement in vision in these giant macular holes?
Yes, ma'am. So the patient did achieve about a 660 kind of vision, and the only mistake I did in this was one of my first cases. The size of the graft was a little smaller. You have to take at least 1.5 times the size of the graft, because it always retracts. So always a bigger graft. In the future, I've started taking
Did the detachment settle?
Yes, sir. So because I did air fluid exchange, sir, and then did laser also. So it was a pre-existing detachment, so it made my work easier. Otherwise, I would have had to use a 42 gauge cannula to create a detachment and then make the retinotomy. But this patient had a pre-existing retinal detachment in the inferior and the nasal periphery.
Thank you very much.
Thank you, sir. Thank you, ma'am.
So the next speaker is Dr. Piyush Bansal. He'll be presenting surgery for macular hole.
Very good morning to the respected chairs and to everyone over here. So there's going to be a lot of overlap and wonderful videos, Dr. Luthra sir and Dr. Saurav. So as they already said, we do a vitrectomy and ILM peeling with internal tamponade for these holes. So I'll just show a couple of scenarios myself. So this was actually the first macular hole that I had done, which was around a decade ago. And as you can see, the video quality is comparatively poorer, and my technique is slightly more primitive, wherein after doing a vitrectomy, I'm I'm peeling the ILM across the macula. And just to tell you a little bit about the techniques, which Saurav sir has already covered. So what we do over here is, after doing a vitrectomy and initiating a pinch and peel of the flap of the ILM, we go around the macular hole, similar to a capsular excess. So we can call it kind of a macular excess. And it's not necessarily to go from arcade to arcade, but if it's possible, then as much of peel that is possible to do, it always helps to release traction. Now, there are these holes which are larger in size, especially around 500, 600 microns and larger. In those cases, we just don't peel the hole. We pretty much shift it to doing an inverted ILM flap, wherein, again, like Sir said, we do a cauliflower kind of a peel, or what we can do, what you see over here is a 180 degrees peel. So beginning from one side and then going on to the opposite pole, and then beginning again from the other side, so that you have a residual flap which doesn't accidentally tear off. Which doesn't accidentally tear off, and you have this flap. Essentially, you're keeping it so that it acts as a scaffold for the hole closure. Doesn't necessarily amount to improvement in vision always, but anatomical success is definitely higher with these kind of situations. Another traumatic hole, like Dr. Santra had said, these holes, the ILM peeling over here is not as difficult as other routine holes, but PVD induction is extremely important. That can be a tough one. Now, as you see over here, I pretty much use an ILM peeling forceps. I don't use diamond dusted forceps, or I do use finesse once in a while when it's an extremely sticky ILM to initiate a flap. And as you can see over here, lifting the ILM flap and going step by step and slowly, so as not to create any more undue. Now, I want a flap residual over here, so making sure that I don't accidentally rip it off. And once you have some amount of the ILM flap still attached to the edge, one can trim it if required. As you can see, trimming it with a cutter over here, or one can just leave it as it is also. But what I find is, if I trim the flap adequately, the chances of the flap moving after I do a fluid air exchange is comparatively lesser. You don't really need a lot of tissue over there. This is a retinal detachment with the break as well as a macular hole. So this is a comparatively older video. Again, after doing complete vitrectomy, going on to the periphery and shaping the base and making sure that all the vitreous is removed from around the flap, from around the break. This is extremely important when you're doing any retinal detachment surgery, making sure that there's no vitreous attached to the anterior edge of the break. And after doing this, then shifting my attention to the macular hole. So again, initially I was using PFCL. Now I pretty much stopped using PFCL, but I still use it when it's an extremely bolus detachment. So despite doing fluid air exchange, I still have fluid collecting underneath the retina. So in those situations, I put in PFCL. You see that's giving some amount of counter traction. So that makes peeling of the ILM comparatively easier. One can easily take a large PFCL bubble also. I can see that there's a nice area of ILM peel around the hole. Then going back to the retinal break and doing a fluid air exchange. Then treating it as a routine retinal detachment. And after doing that, you do a endolaser around the break. I don't necessarily do a 360 degrees laser in most of these situations, as long as I've identified that there are no more breaks or any lattices that can open up, and then do a silicone oil injection. This is how I pretty much manage most of these macular hole RDs, which don't have another break. Don't necessarily put in PFCL, and it's not that difficult to peel the ILM in these detached retinas also. As you can see over here, one just has to be a little more patient. Again, it's a larger macular hole, so I would want to leave an inverted flap. So a similar technique, a 180 degrees peel, and then leaving some amount of the ILM attached to the edge. It's important not to stuff it over there, as Sir has already mentioned. You don't want to damage the RP. Never drain fluid from the hole itself. You create a separate retinotomy, and then you drain the fluid. Now, this is my senior colleague, Dr. Rupakanti Biswas's video. Again, I haven't done these autologous grafts, but what he does is in these macular failed holes, he uses these trephines to actually cut piece of the retina. And this is a 550 micron trephine. Like Sir said, you want a slightly larger piece of retina as compared to the hole because there is contraction. And now he's going to place it at the hole. So he's actually made multiple trephines, and then he sizes them accordingly. And of course, you after doing this, you laser around the area of the retinotomy. Thank you very much.
Thank you, Dr. Piyush Bansal. So any questions from the audience?
Mike.
Yeah.
Thank you.
Uses the trephine and then so that is an advantage, but can be done under PFCL. It's not very, we are not very sure, but it's better to keep the alignment of the retina. It should not kind of turn over.
Yes.
So you should have the vitreous facing, the surface that ways only, and it should not, turn, because
Very
otherwise then you will have a misalignment. For that, if you are using PFCL, it is always recommended that to have a large PFCL bubble, so that there is no air PFCL interface, because when you move from the air to the PFCL, then it has a chance to roll over the faucet's tip. So these are some small points which can be kept in mind.
Thank you, Saurabh.
That's a very important point. Thank you, sir, for sharing. So one more thing I wanted to add was when you added PFCL in your holes, what about the idea of just putting in some viscoelastic instead of PFCL? Does it because I have had some cases where okay. Okay. Thank you.
I think we'll go on to the next topic. Dr. Vinod Kumar will be speaking on pneumatic retinopexy for regumatogenous retinal detachment, timing, when to do, when not to do, and follow-up.
Good morning, everyone. So today I will be speaking about pneumatic retinopexy, that my experience in the last 1 year. So although it was discussed back way before 35 years as a two-step procedure by Hilton and Gizzard, it actually involves injecting a gas bubble inside the vitreous cavity that is coupled with must laser or cryotherapy. Because of the advancement in pars plana vitrectomy or better buckling techniques with chandelier assisted buckling, and also this pneumatic retinopexy lost its charm. The indications for pneumatic retinopexy that was discussed 30 years back were the breaks which were there in the superior part of the retina, that is anywhere between 8 to 4 o'clock meridian, and the breaks should be within 1 hour clock meridian. And if there are any breaks in the inferior retina, the retina should be attached, or if there are any lattice degeneration or peripheral degeneration, they are allowed. So the exclusion criteria is the inferior break in the detached retina, significant media opacity, or if there is a development of PVR, and if the patient is not able to maintain his position, mental incapacity, or the patient, younger patients, or one-eyed patients. So with the advent of better imaging techniques and better scleral depression examination, the criteria can be expanded to more clock hour breaks, or sometimes the number of breaks can be more than one, and if the breaks are more than one, the multiple change in position can be done to treat the retina. So the greatest success of pneumatic retinopexy is appropriate case selection. So thorough scleral depression examination is must to look for all breaks, even though they are in detached or attached retina, and also look for all peripheral degenerations which are likely to open up post gas injection. With the advent of optos or ultra wide imaging, this scleral depression work has been partially replaced, but scleral depressive examination is very must. So the beauty of this procedure is can be done on the same day, but things to be considered about the positioning, especially that if the patient is of old age or cervical issues or back or spine issues, they should be counseled accordingly. we usually perform, I usually perform inside operation theater, and in indirect laser or laser through the slit lamp delivery is must within 24 to 48 hours or as early as possible. Cryotherapy can also be done. All the aseptic precautions as we take for intravitreal injection and AC tap so that the eye is made soft. Take fluid as much as possible. For case of pseudophakia, we can go to the needle can be taken up to the center of the pupil and remove as much as fluid, as much of AC tap as possible, and inject the gas at around 3.5 for pseudophakia and 4 mm for phakics, especially away from the bullous component, and try to be in superior nasal or superior temporal component. So what is the appropriate gas bubble we should inject? There is no such criteria, but ideally it should be around 3.3 to 0.4 ml more than the AC tap, or it can be higher in case of myopes or slightly lower in case of hypermetropes. SF6 can be injected up to 0.5 or 0.6, C3F8 can be injected up to 0.3. SF6 is a better option because it goes away within 2 to 3 weeks, whereas C3F8 stays for more than 35 to 40 days. So the tableau column shows this is the arc of contact for non-human eyes. Even for the human eyes, if you inject 0.3 to 0.4 ml, you can give an arc of contact of 45 to 50 degrees also. So once we go inside the vitreous cavity perpendicularly toward the center of the eye, gradually withdraw the needle and inject the gas bubble very slowly, and once you take out the needle, put a small cotton tip bulb so that the air or vitreous should be, it will not come out. So post injection, if the detachment is macular on, prone position should be given for at least 6 hours, maybe more than that, so that the macula gets settled first. If it is done for macular on detachment, earlier we can ask the patient to lie in the position of the brake for initial 2 to 3 hours of prone position. If it is not on the table, if not possible immediately on the table, patient can be shifted to the bed, or it can be stream lower maneuver is the technique where patient is made to lie supine for some hours and gradually with 30-degree increase in the elevation of the head, so that the bubble directly tamponates the brake. So laser is a must, as I was telling. So routine post-op medications, and always avoid, tell the patient to avoid supine position to avoid cataract or pupillary block. So this is my short case series where almost 12 patients were fit for this PNR. After convincing, 8 patients got ready, and of all these, 6 patients are doing well. 2 patients developed reed detachment, one because of macular hole detachment, other developed a new hole. So this is one of my case where the patient presented with a temporal hole. You can see 2 holes are, one larger and a small hole. So identifying a small hole is also makes a big difference here. So there is a detachment coming up to the macula. So this was the day 1 picture. I injected a gas bubble and did a laser on the same day, and the patient is doing well, 6/6 vision. So this is another patient where the macula is also off, completely off. So patient was injected. There was still media, but I could do the laser in the slit lamp and cover the superior brake, and patient did well. So what I haven't tried is the brakes more than 6 clover apart, and I haven't tried rebubbling in these cases, and I also haven't tried cryo. But these are all discussed, and they are people are doing this. So the cases where PR is particular advantage, phakic eye, especially young patients, macula on cases, bullous already where you have already identified the brake, and it is a very less expensive procedure. It can, but we do under operation theatre. It can be done in the OPD also. The more advantage with the pneumatic retinopexy is better physiological attachment and lesser chances of metamorphopsia. I can see this is the case of post-VR vitrectomy detachment. You can see the inferior part of the retina is getting displaced, and patient will have metamorphopsia with these kind of attachments. Pneumatic retinopexy has better advantage. So disadvantage is smaller bubbles, fish egg formation. So conclusion, pneumatic retinopexy has a better results, minimal morbidity, and even if PR fails, vitrectomy is also the option is still open.
Yeah, very nice presentation, Dr. Vinod Kumar. Thank you. We'll take the questions in the end. So may I now invite Dr. Rajkumar Sharma. He'll be presenting on the dying art of scleral buckling.
morning, Mr. Chairman, sir, madam, all the distinguished audience. I would like to touch upon a topic very close to my heart, very sensitive about this, and especially after hearing the heroics of people like Saurav Luthra, Saurav Santra, and Pankaj. This is because scleral buckling we have been doing, and I know the chairman sir must have been doing it for last 50 years. I have hardly an experience. Yes, I hardly have an experience of about 32 years. So since its introduction in the 1950s, scleral buckling has been a highly successful technique for the repair of rhegmatogenous retinal detachment. But the popularity of this art, I would call it as an art, is waning gradually. I will discuss the reasons for that. The decreased practice may be partly due to recent advances in the machines. Now we are using 10,000 cuts per minute, and instrumentation, visualization system, the wide angle viewing system of the microscope, the intraoperative OCT, as many people are using, is probably making a pars plana vitrectomy more attractive procedure and sometimes more lucrative also. In addition, the inability of the learner to observe their mentors employing intraoperative indirect ophthalmoscopy in scleral buckling poses an additional challenge. So that these days, the younger vitreoretinal surgeons, I'm not blaming anybody. This is the changing times, and we have to accept that. So, I mean, they don't strain their backs and they don't indent, they don't want to indent to see the breaks properly. If they start learning indirect ophthalmoscopy well, I know I have had many fellows from outside India who were surprised that you are using indirect ophthalmoscope for managing a retinal detachment. So this is a fact. Despite these issues, scleral buckling is the preferred treatment modality for many indications because it has lower costs, it avoids many of the potential complications of vitrectomy, it also preserves vitreous, which may be useful in future where you have to give an intravitreal injection. So every month we get about 4 to 5 cases of detachment who are referred to us for buckling, belt buckle vitrectomy silicone oil, written clearly, and it is not done by a general ophthalmologist. These patients are referred by trained vitreoretinal surgeons. Out of these 25 cases per year, we get around, we operate around 25 cases, and out of these 25 cases which were supposed to go for vitrectomy silicone oil, second surgery for silicone oil removal, we do buckle, and more than 80% we are able to settle. Maybe in rest 4 or 5 cases, we have to do vitrectomy later on. So I want this trend to be reversed. We should try buckling in many cases. My indications are different. So advantage of scleral buckling we have already discussed. The cost is also low. You know, the machinery cost of a buckle, there's hardly anything, indirect ophthalmoscope, cryo, that's all. But PPV, as I said, is more financially lucrative in India also these days. So more people are doing vitrectomy. The number of cases of vitrectomy is going up and up and up, and scleral buckling is going down and down. These are the Medicare data from UK. So you all know the definition of a buckle. How does it work? It reverses the intraocular fluid and the forces. So management in brief includes identifying and sealing all the breaks with retinopexy, draining if required, and then tamponade, which may be external like buckle, or an internal tamponade. But a thorough preoperative examination is a must, and accurate drawing of the retinal detachment should be there. Scleral buckling is done like this. So why I am not against vitrectomy. I am just discussing the pros and cons of vitrectomy and buckling. If you avoid vitrectomy, the reasons to avoid vitrectomy may include posterior hyaloid remains quite adherent, especially in younger patients, which may be difficult. Vitreous is more formed, so itself can help to tamponade the retina with an internal tamponade. There is higher rate of cataract formation after after vitrectomy, and the risk of redetachment after silicone oil must be kept in mind. And in various series, it ranges from 10 to 15 to 20%. So, and my feeling is that vitrectomy is the most unforgiving of any ocular surgery. There are many case series where they have done buckling for all types of cases, including PVR up to PVR-C. Phakics, yes, it does have advantage, and many people do agree that yes, phakics, young patients, inferior RDs, dialysis, we should do buckling. I agree to their point. But what I want to say is, I would like to give this opinion that buckling can be done in all buckleable cases, whether phakic or pseudophakic. There's a big controversy and discussion going on that no, in pseudophakics we should do vitrectomy. I don't agree with that. There are many series where we can prove that. In a short series of collection of cases which we published recently after doing 5,000 bucklings, and to top that, more than 10,000 vitrectomies for RD, vitreous hemorrhage, etc. Not that we don't know vitrectomy, not that we don't have instruments, but we should do buckles also. So in our published series of 200 something cases, we could conclude that scleral buckling, when done appropriately in the appropriate cases, gives the maximum visual outcome with the least cost and the need for consecutive procedures. The visual acuity in our series doubled in almost more than 80% cases. And 67 pseudophakic RDs were also there out of these 200 cases, where 59 were settled with buckling. So the success rate was 88%. Many such cases, I don't want to go into details, maintaining vision 6/12, 6/9 after even 20 years. So recently we got some of the cases and their wide angle photographs. You can see the retina is beautifully settled. Just 1 minute, sir. See, this is one case where the patient was advised transparapilar vitrectomy, membrane peeling, fluid exchange, endo laser, silicone oil, and look at the drawing. This patient was operated for buccal, and the vision improved to 660 on day 3. Another patient, wide angle photograph, recently operated. Another patient, retina settled, visual acuity was 636 after 3 days. There are complications of vitrectomy. Most common is the failure of the vitrectomy, but still it is a time-proven technique, and this is waning due to recent advances in machines, instrumentation, visualization system, and despite these issues, buckling is preferred technique in many conditions. It entails lower cost. Thank you. So my indications, again, phakic, pseudophakic also should be included.
Thank you.
Many questions?
Thank you,
I know
Dr.
there will be
Sharma.
many questions.
As you said in the beginning, I am doing it for last 50 years, and I am still doing it. Although my age prevents me from doing active surgeries. Recently, I read an article
Sir.
that it is upcoming in America again, and some centers are doing 40% scleral bucklings. I am a
That's
member of a WhatsApp group of Retina with 1,000 members worldwide.
Yeah.
And even in that, people are saying that scleral buckling is coming back. So don't be disheartened.
Thank you,
very
sir.
much.
Thanks for the encouragement. Thank you.
Thank you, sir. May I now invite the next speaker, Dr. Bhuvan Chennana, who will be talking on GRT management, tips and approach.
So very good afternoon, and thank you chairpersons and AIOS for giving me this opportunity. So I think GRT is a condition which can be mostly managed through vitrectomy only. I think it's difficult to do a scleral buckling in most of the cases, although I also do a lot of scleral buckling. So I'll just be going very fast because I have few videos and few tips which I just want to share. So I think we all know that a GRT or a giant retinal tear is a break which is more than 3 clock hours. So what are the treatment challenges? So the main thing is that it is a unique in presentation. Because of their size, it can have radial extensions, it can lead to severe PVR, and it can also lead to higher chances of redetachments and failures. So how to prevent this? So the first challenge is whether we have to sacrifice the lens or not. I think with improvement in the technology, with the smaller size, wider view, we can mostly save the lens in most of the cases, but sometimes it is better to be compromise the lens if it is cataractous, you're having a difficulty in doing the anterior vitrectomy, if it is associated with severe proliferation of anteriorly, or in a case of a redetachment, then it's always better to remove the lens and do a good vitreous base dissection. So this is one of the first videos which I did. This is a 20 gauge vitrectomy, so a very old video. So you can see it's very important to do a complete vitrectomy, especially along the edges. PFCL is like a third hand in GRT, it's very essential. So it's very important to remove all the epiretinal membranes which are present at the edges. That's very important for all retinal detachments. So you have to release all these membranes which are attached. So in this case, I'm using the endolite and the cutter to separate the forceps. Then I removed the lens as it was cataractus. So this was a traumatic case, a young child. You can see this is a near total giant retinal tear. A very good dissection is very essential along the edges of the GRT. Further removal of the membranes which are present infero-nasally, then a complete fill of PFCL. It's very important to have a complete fill. You should have the PFCL coming into the infusion cannula. You also have to be careful that the IOP is not very high. And following a complete fattening, there should be absolute dry edges. You should do around 3 to 4 minimum layers of 360-degree endo laser all around the GRT. And I usually do not do a PFO silicone oil direct exchange. I prefer to do a air exchange to see whether there is any slippage or not. And then probably you can also use gas or you can inject silicone oil. But this was an old case, I injected silicone oil. So whether the use of encirclage or not, I personally do not use it in simple cases. Probably if there is a lot of anterior PVR, I will use an encircling agent because it can lead to slippage. But some of the factors which favor it, they say that it supports the vitreous base and can increase the success rate. But I will use it in a case only when there is extensive PVR. So how to prevent slippage? As I said, a very good vitreous base dissection, a complete dissection attachment of the vitreous along the edges, a complete PFCL fill to have a dry edge. And you can also try a direct PFO silicone oil exchange rather than doing a air exchange, which I usually don't do. So this is another video. In this I wanted to highlight a technique. So this is one important tip which I have learned and I also read, that these small radial extensions, if you give it, they really help to reduce the traction, the radial traction, and increase the success rate. So I'm removing the anterior edge of the retina because sometimes it can lead to neovascularization. So these are the small radial cuts which now I routinely give in all GRT patients. It really reduces the chances of the slippage and the flap rolling back. So I'll just tell you the logic behind these radial cuts. And I also went through the books, and it's already mentioned in the Ryan that radial cuts are very important for prevention of slippage. This is followed by endo laser and silicone oil injection. So there are two types of tractions which are happening. One is a tangential traction and one is a radial traction. When both of them are more than the force of attachment, then it will lead to a slippage or a chances of a redetachment. So what happens with this radial relaxing retinotomy is we are releasing the radial traction as well as the tangential traction and trying to make the force of attachment either more or equal to it. So a radial, the small radial extensions along the edges and maybe one or two in between the retina, they really have increased my success rate and decrease the chances of slippage if I do a air fluid exchange or redetachment rates also. So I think this is the most important thing which I wanted to tell through this presentation. Now this is the second most important thing. This is the last video, it's a bit long video. So this is a case which has got severe PVR, a gone case. I didn't want to operate, but the patient really wanted to go surgery. You can see the bare choroid. In this patient there is extensive PVR, the retina is just completely rolled up. So this is something, a hope surgery I'm doing. So I'm trying to, after doing a vitrectomy, I'm just gently removing the membranes. There was a site of retinal incarceration which can be seen because this is a traumatic one. So just removing the area of the retinal incarceration, injecting some PFCL to get some surgical space, and gradually removing these proliferative membranes and trying to open up the retina. So what I observed is that I think if you're very patient and you go very slow, maybe in some cases you might achieve some success. So there is a lot of contracture here. So here I decided that I should probably do a relaxing retinectomy. I did a retinectomy, I've injected PFCL, and now I'm doing a removal of the ILM to further try to relieve the traction at the posterior pole. You can see the fovea is just displaced below the disc. There is so much PVR. So after releasing all the peripheral membranes, doing some retinectomy, I did this removal of the ILM, which was very boggy and tightly adherent. Further retinectomy. So in this case, I decided to leave PFCL. So now this I do routinely in severely cases with PVR D3. I leave PFCL as a temporary tamponading agent. So under PFCL, I've done laser. I've left PFCL, and after about 10 to 15 days, you can see the mark change under PFCL. So the fovea is coming back to its normal position. Removal of residual membranes which are there. Now what I'll do, I'll remove this PFCL. For 15 days, PFCL will not cause any problem. And then I'll replace it by, I'll do a air fluid exchange again to look for any slippage, and I put silicone oil. So the anatomy has improved so markedly. This is the first intraoperative picture, and this is the second. You can see the fovea is coming back to its position, and the retina is looking much better. So I use this two-stage technique even in severe cases of PVR. The OCT picture has become normal, the retina has become normal, and the patient has also gained some vision in these cases. So not only in such poor cases, but also in any RD with PVR D3, I now routinely use PFCL as a temporary agent and do a second setting surgery after about 14 days, remove the PFCL, and it has really increased the success rates. So just to conclude, I think successful management of GRTs, the main thing is a very good vitrectomy, a good vitreous-based dissection, removal of all the vitreous attachments at the edges of the break. PFCL is very important. You have to have a complete dry edge. PFCL should come up to the infusion cannula, a good laser, and PFCL can now also be used as a temporary tamponading agent. Relaxing radial retinotomies have also really released the radial in the anterior-posterior traction as well as the tangential traction and increase the success rates. So thank you.
Thank you. Thank you, Dr. Chandana. This is GRT is one condition we cannot do scleral buckling in. I tried in the initial stages, pre-vitrectomy era, and the retina settled for about 3 months, 4 months, ultimately gave way. So it cannot be done. What are your success rates?
So it depends. See, if a fresh GRT comes to me, I think the success rate with a vitrectomy would be more than 90%. But such case, if there is severe PVR, then it's very difficult to predict a success rate. Maybe even if a 10 out of even if I give 2 patients some vision, I think I'd be
some
very lucky.
ambulatory vision.
Yeah.
Thank you. Nice surgery, sir.
Okay, one question.
Yeah. I don't use bands. In fact, I don't even think now for anterior PVR I would use a band. What I would do is rather do a retinectomy, relaxing retinectomies, and a PFCL tamponade. So I personally do not recommend to use a Fencercler, but some surgeons use it, so I just wanted to tell the indications. No, supine. The patient has to stay supine.
I'll interrupt in a minute. Is Dr. Pushkar Dheer and Dr. Bhanupriya here? You are Bhanupriya. Okay, so we have one speaker missing, so we can have 2-3 minutes to our discussion. Please come here. Dr. Bhanupriya, please start your. Oh, Pushkar Dheer. Okay, so discussion stop. Please start your talk. If time permits, we can discuss in the end. सभी आ गया.
Dr. Pushkar Dheer will be talking on Beyond the Retina.
All right, so good morning. Still it's late, good morning everyone. So we started from beyond the surface and to the macular hole, deep diving, and now we have reached something which is beyond the retina. So I will be talking on something related to the approach to the subretinal masses we all encounter during our routine OPDs. So this is a normal tessellated fundus which we experience in our OPD every day. But what if this tends to fall off? So recently Dr. Bhuvan has shown a very good video of a GRT and the same kind of complex cases I also experienced. But I went around to understand, I also operated such kind of cases, but today my topic would be more related to the masses which are originating from probably the choroidal area. That this is the RP, which is there once the retina has fallen off. So this is the RP, and beyond that is what is all the choroid. So I'll be focusing myself towards, so this is the hole we have in the retina surface, the hole, and I'll be just focusing towards the last part, that is the RP and beyond that. So once we look at the RPE, so we have the RP, and then there's a Brooks membrane, which is a composite of basically a basal lamina, collagen, internal and external collagen, elastin, and then the basal lamella of choriocapillaries, where a lot of things start originating. So I'll be going ahead with all of these things. Last year, I have experienced this new term, which is BLAMD and blind, which is basically the basal laminar deposits and the basal linear deposits. So these are the kinds of new deposits, and the terms are originated from the different kinds of OCT which have been appearances which have been coming up. So if you see a marked laminar deposit type of picture, which is usually between the Brooks and the RPE, it's usually the mark that the patient will develop a neovascular AMD in future. But if you tend to find a basal linear deposit, these kinds of deposits are usually in the inner layer of the Brooks membrane, which is the inner collagen layer, and they usually tend to be a soft brucins in the future. So if you see an OCT over here, so this OCT shows clearly a area of a BLAMD layer. So this probably will go in future as a neovascular AMD. So as we progress, we have seen different kinds of photographs. When we experience such kind of fundus pictures in our daily routine OPD, we tend to see it's a hemorrhage, and we try to diagnose it as subsequently as an IPCV. So usually what we require to diagnose such thing is an ICG, where we will see that though the main polyp is somewhere here, and the bleeding, it's all the bleed over here. So what is basically happening in this IPCV is that we have some vessels which are getting originated from the choriocapillaries and then displacing the RP itself at a particular point. And when we try to correlate it with the OCT, so you see that the Brooks is elevated to a certain area where the blood vessels are traveling, and then there you have a polyp originating in these areas. So once we talk of the subretinal masses, when we see such kind of OCT, we tend to diagnose it in the form of a mass or a lesion per se, could be an osteoma, hamartoma, tuberculoma, what it could be. So I'll try to brief few of the cases in my coming up slides. So this is a kind of OCT we experience in a lot of neovascular cases. So I've compiled it accordingly. So this was a case I discussed within an IPCV, but if you tend to correlate this OCT with this OCT, they tend to show you the same RPE alteration in both of them. But then there's a difference where you see a double layer sign, it tend to be an IPCV versus an occult CNVM per se on the OCT itself. And then you have the RAP lesions, but then they are entirely different, but the OCT still shows the elevation, and you have a dome-shaped OCT in them also. But then it has to be diagnosed with a fluorescent angiography. So in my OPD, I have experienced this kind of cases, not very regularly, but then they have come across, and I have tried to compile them and tried to diagnose it, because they all appear to same to me in some or the other way. And using my clinical knowledge as well as the machines, I have tried to reach a conclusion which I'll be sharing with you. So these are few of the differentials we have in our OPDs when we see a subretinal elevation on OCT. And these are few of the diagnostic tools which we probably have. Beside, the most important part is the brain, which actually relates all the findings, and then we come to a conclusion. To approach such kind of masses, we need to have a strategy to devise it out where we are heading towards. Is it a infectious pathology, or is it something, a lymphoma or an hemangioma? So usually a good clinical evaluation, we need to check for the vitreous cells and see if there is an activity. We need to see the location of lesion and the contour pigmentation, which helps us to diagnose the cases of melanomas, and the association with age and gender, which help us to diagnose osteomas. And in diagnostic evaluation, definitely OCT has come handy to tell us is it a sub-RPE or sub-retinal lesion, and a B scan to tell us that if there's a calcification in that mass or not. And an FFA and ICG definitely is a helpful in recent times, but FFA is also good for many of the cases. And then definitely your own EUA, by doing EUA, you can just look at the lesion itself. So first of all, I'll come to one of the lesions which I have experienced recently. It was a yellow-white lesion with minimal elevation and small. Whenever you find a small network of vessels and a yellow-white lesion, and on OCT you see a non-acoustic lesion with lot of the hyperreflectivity seen on the OCT, and on B scan, if you see again a high E-code A scan noted, you tend to think in terms of an osteoma. And then the locations are usually juxtapapillary, and as I have already said that it's a high internal reflectivity and a back shadowing would be there. So similarly, continuing the same, when you see a lesion again in a juxtapapillary area, but this time the OCT is something different, and it is more or less a acoustically solid area which you can see on an OCT. And then similarly, a second photograph of another patient where you see another acoustically solid photograph, an OCT, and then you tend to do an FFA and try to realize that the hyperfluorescent area with a fine lacy pattern is coming out. And then even an ICG can be helpful. This is an artifact, please ignore this point. So you can probably diagnose it to be a hemangioma case. You need to see that it is a reddish orangish color, and it may be circumscribed or diffused. I'll just completing in a minute. And when you see a mass like this lesion, which is a gray colored dome or mushroom type, and with an acoustic haloing. When I mention acoustic haloing, it's usually on the B scan where you will be finding the different areas and an excavation behind the mass. So usually you will be thinking in terms of the choroidal melanoma. And then definitely you have the mnemonic to find small ocular melanomas using helpful hints daily, which suggests you which is a melanoma versus all the pigmented lesion where you will think that it is a kind of a melanoma. And this is one of the last pictures which I experienced where the OCT had this lumpy, bumpy appearance. Finally, we could nail it down to a METS where the patient had a primary site in the lung, and then we could diagnose it on OCT where we had a lumpy, bumpy appearances. And it was a retrospective diagnosis where we saw the OCT first and then we diagnosed it as a lung cancer case. And when we experience conditions like retinoblastoma versus the coat, so you need to figure out the calcification. In the first picture, you will see an exophytic, and in the coats, you will see a lot of telangiectatic vessels, which are...
Please wind up.
Yeah. So with that, I like to end my slides. This was just to bring the more concern towards the subretinal masses. With that, thank you so much, everyone.
Yeah, very interesting cases. Next, I would like to call upon Dr. Bhanupriya, who the title of her talk is I Am Confused.
A very good morning to all of you. So today I'm going to discuss about a patient whose clinical course really confused me. So this is the story of this gentleman, 57-year-old male, who presented to us on 2018, came for regular checkup. He was hypertensive and diabetic. On clinical examination, the best corrected visual acuity was 6/6 in both the eyes with myopic correction of 2.5 in the right eye and 2.75 in the left eye. And the rest anterior segment was within normal limit. On posterior segment evaluation, the central fundus was within normal limit, but on the peripheral examination, in the left eye, there was a temporal retinal break was there with the surrounding pigmentation. So as the patient was asymptomatic and there was no risk factors associated, like there was no association of any trauma, there was patient was not undergoing any ocular surgeries, so we decided to follow up this patient in 6 months. But patient came after 6 years with the sudden vision loss in the left eye, and the visual acuity was finger count at 3 meter. On examination, left eye retinal detachment was noted. So 6 years earlier, when we saw this patient, there was a temporal retinal break, and now the patient came with this retinal detachment. There was no other peripheral retinal degeneration was there. So apparently the same break which was noted 6 years earlier is the primary break. So I am confused here, like, have I done any mistake? Should I have lasered 6 years ago this lesion? My single 5-minute procedure could have prevented this mishap. But what does the protocol says? As per American Academy of Ophthalmology, the asymptomatic tears, asymptomatic retinal round holes, treatment is rarely recommended. Patient should be kept under observation. So I think as per protocol, I have not done any grave mistake here. So what are the conditions when we need to laser these degenerations? As per IGO, when the patient was asymptomatic, if the patient is single-eyed, if the fellow eye is affected by an RD, if patient is undergoing any cataract surgery, refractive surgery, laser capsulotomy or intravitreal injection, and if there is a family history of RD and there is inability to assess any ophthalmological care, then we need to laser these lesions. I would like to highlight that the prevalence of asymptomatic retinal break is approximately 6%, and the cumulative incidence of retinal detachment by an asymptomatic retinal break is ranging from 0 to 13.8%. So if we think of lasering all the asymptomatic breaks, we know the world population is 8 billion, 6% will be 480 million, and we will end up lasering 480 million people, which is practically not feasible. So I think I did right here, but how can we avoid this regrettable incident? I think that proper counseling is the key. We need to explain the patient about the symptoms, not only when they will come to you when vision will, we have lost the vision. So we need to explain the patient about the floaters, flashes, along with that if they are seeing any dark spots, any sluggish lines, and if there is loss of peripheral vision also. So we need to explain very carefully to the patient, and we need to follow up this patient. Thank you so much for your patient listening.
So any history of trauma in this patient?
No, ma'am.
No.
No, ma'am.
So traumatic breaks also, they don't follow any rule because the vitreous becomes degenerate very quickly,
Yeah.
and then
Yes. There was no risk factors.
no risk factor.
Thank you. We have 5 minutes if anybody has any comments or any question. Yes, Dr. Rajkumar.
Okay.
One thing. Second thing is, I don't know, you must have seen the patient carefully with the dynamic indentation, palpation of the retina. If you see some pigmentation, but maybe the hole was not, I mean the pigmentation was not all around. So that is why maybe some fluid has gone into this. If you are talking of the world incidence in 480 million, no, you are not going door to door and doing a screening survey and then
Yes,
saying
sir.
that we have to treat 480 million. These are some of the patients who are coming to you. If they come to you, if you see a break which you think should be treated, it should be treated. Thank you.
I think other criteria like if it is high myo, if the other eye has, if there is a family history, anything which might predispose should be kept in mind. And I think, as Dr. Rajkumar said, indentation is very important in these cases. If a
Yes, sir.
peripheral, you see a peripheral hole, not a tear, but a hole with pigmentation, you indent it.
Yes.
And if you indent it, you will see the pigmentation is not all around, especially at the towards equator. So indentation is very important, and other predisposing factors should be kept in mind.
Yes.
But it is your patient, you have to treat, you have to warn. If I had a patient like that, I would tell him that the earliest possible symptom you must report.
Yes, sir.
But that is only if the pigmentation is fully around.
Noted, sir.
It's difficult situation. As you
Yes,
said,
sir.
everybody is confused.
Yes.
Thank you everybody for
Thank
your kind attention, and I find half the hall is full. That is very good. Yesterday I chaired a session in a big hall and there were only 8 in the audience. Thanks very much.